for instance, an Ain colleague to come and have a regular online clinic. He would understand the concept and he would love the concept, at least for Ramiz. But then to have a dedicated time every week to come and sit, it just needs some time for them to get the concept and to feel comfortable seeing patients this way. This is on our side. On the other side, yes, it's very different. Sometimes we see, that's why there are different levels of cooperation. So some center will just sit for one lecture online and that's it, present the case and that's it. But then many of them would shy from presenting cases but would just attend lectures. And then some others would go even further, like the center in Africa or another center in Kafr Sheikh. We already know them because they have all graduated from Ain Shams. And they want to work with us and join our telestroke network. So just different levels of how people want to cooperate or how to see themselves working with us. But yes, it's a very relevant point in terms of everyday practice.
And it's a dream that's just starting and with very good opportunities to develop, inshallah. And we hope you find a way for better platform established and better marketing, of course, and better establishment of communication ways to other doctors and the patients, like Hakim said. It's just starting, and it's a dream that's just starting. We hope it grow up.
Right, thank you. We invite the next speaker, Dr. Shahinaz Hilmi. Dr. Shahinaz is a lecturer of neurology at Ain Shams, and she's going to speak about the uses of technology in headache.
Okay, dear professors, dear colleagues, good afternoon. I will talk about the good face of technology and application in headache management. And I mean by good face that we all know that the use of technology to headache patients could be harmful in certain situations. But with the new advances of technology and the capabilities it offers, how can we use this in a proper way to make a headache patient benefit from it? So I will give a review about the idea of teleneurology, and specifically I will concentrate on teleheadache. I will give an idea about the mobile technology advances and the headache app. And finally, I will highlight in brief the experience of Ain Shams University regarding this issue. So first about the teleneurology, as was mentioned by Professor Najib and Professor Tamer, we have a problem in the current neurological care. There is a deficiency, and this problem is more in the developing countries. However, even in the high-income countries, the access to neurological care may take a long time and may affect the prognosis of the case. So came the telehealth, which is a new model that can limit this gap. It compromises the use of technology to provide healthcare, education, and remote monitoring, either with asynchronous way like video audio conversation between the patient and the doctor, or even by asynchronous, as using the SMS, as the WhatsApp, or even the email. This could help also. The application of telemedicine in neurological field is termed the teleneurology, and according to the definition of WHO of the telehealth, we have many applications for it. So it could be a patient-doctor consultation, where the patient living in an isolated remote area where the deficiency in the specialist can, without the need for travel or waiting a long time. Or it could be a consultation between the doctors, the specialists, and the young doctors, the GPs could benefit from it. Also, it gives a way for the learning and research purposes and collecting data. And of course, all of these will reduce the cost and increase the efficiency. So still there is challenges and some barriers for its expansion. We have concerns regarding the doctor-patient relationship, concern regarding trust. Some points in the examination, for example, our neurological examination, sometimes there is certain issue cannot be performed by remote monitoring, like for example the tone or the reflexes, and this could be overcome by a telepresenter that could be manage the neurological examination and provide it to the experienced or specialist. Also, we had barriers related to social, political, cost issues, and all of these barriers could be overcome later on, inshallah, for better practicing. So why do we need teleneurology? As I mentioned, we have a problem in the neurological care. We have a deficiency, and the neurological diseases by itself is a burden for the individual and have socioeconomic consequences. And if there is a delay in management, it will affect this more. And in a certain situation, we need a rapid expert evaluation and management, like, for example, stroke. And so we couldn't be able to increase the number of neurological resources all over the world. And the other alternative could be the application of telenetwork, which could provide high-level neurological care. In neurology, it could be applied in acute conditions, and the most successful example, as said by Dr. Tami, is the Delhi stroke, which is proven to be safe and efficient and timely efficient. And the other non-urgent evaluation in the chronic neurological condition, also it is very important to be managed by telemedicine, because these conditions could affect the mobility of the patients, the cognitive, so it could be a barrier for the patient to go and see a specialist. So I'm now concentrating about the headache. Is headache suits to be managed by telemedicine? So as we know, headache is a widespread, is a very prevalent disorder in the population, and even it seems trivial, but actually it affects the function of the patient and their daily life. And even in spite of the large number of evidence-based treatment, but actually many individuals don't receive this proper care. And this could be due to many reasons, like a problem of awareness, like deficiency of a specialist at the proper site. And we see also that the diagnosis depends mainly on history, and we have to be cautious while taking history about the red flags to exclude any secondary cause. And most types are mainly primary. So the patient, if you see him for the first time, you can perform the neurological examination. You can exclude any red flags to suspect secondary headache. Then you can follow up with him just by history taking. And so this can be easy to be applied by the remote monitoring or the video conference. So I think, yes, headache could be managed by telemedicine. And now came the other question: is it acceptable? Is it time and cost saving? Is it efficient? Is it safe? And this was answered by a few studies that highlight the use of telemedicine in application of headache. And actually in 2015, a research poster presentation at the 57th Annual Scientific Meeting of American Headache Society highlighted the use of telemedicine and the usefulness of telemedicine in treating headache patients. And the study found that teleheadache significantly improved the patient's likelihood of being prescribed acute and preventive evidence-based treatment. And this was the Norwegian study. It was a large study. It involved a large number of patients. Okay, and this study actually followed up the patient as regard the efficiency, the satisfaction of the patient regarding the telemedicine application, and compare it to the traditional way of management. And actually they found that, as you see here, the satisfaction is not different between the two groups. And regarding the headache variable measurements, it was not different. And then they concluded that the management with telemedicine is not inferior to the traditional way of management in headache patients. But the concern remained about the safety, so they followed up the patient after 12 months, and they found that only one case appeared to be secondary headache, and also in the traditional medicine, it also one case. And they found that the number of telemedicine needed to miss a secondary headache was about 20,000. So they consider telemedicine is safe and it's not as well as the traditional way. In the American Academy of Neurology, they highlighted that for headaches, the telemedicine may be as effective as in-person visit, and this was dependent on the previous study that published on 2017. The second issue I will mention today, and I just will highlight it, is the mobile technology, and also what is called by mobile health. It is the use of, it is a component of electronic health which cover medical and public health practice supported by mobile devices. It's an emerging and rapidly developing field that can contribute to the transformation of healthcare with increasing quality and efficiency. Actually, there is an increasing number in these applications. As you see, from 2010 to 2013, the number increased from 17,000 to 97,000. And in 2018, approximately 50% of smartphone users are estimated to download a health app. But still some concern regarding these applications because there is no scientific evidence-based use for it, and also the low level of involvement by healthcare professionals. So this mobile application should go through a process of assessment in order to guarantee the quality and accuracy of usability. Actually, there are some reviews that studied these applications and tried to set a criteria for a better and ideal application for headache. And the most important is to be designed by a neurologist or a headache specialist, or at least participate in its design. So how could headache patients benefit from this mobile health? We have two main advantages. First, data collection. Patients with headache can use this application for using it as a diary. We all know that headache diary is an important issue. Most patients have to perform headache diary for follow-up of their condition. So typically paper diaries have been used, but it has some limitations. It is bulky, must entered by hand, and may lost or forgotten, and it have a problem with compliance and adherence. So came the advantage of the electronic diaries. It actually have many advantages, and it was shown that it is more reliable, increased level of compliance and satisfaction. And the most important also is that it allows access to healthcare professionals to the patient data in real time. Regarding for behavioral intervention, we all know that behavioral headache treatment like cognitive behavioral therapy, relaxation technique, all are level A evidence in migraine treatment. So goods is managed by or delivered by the smartphones. Yes, actually it could be. And some review found that it gives moderate to high rate of acceptability and visibility, but data according to efficacy and adherence wasn't conclusive, which necessitate further studies. This is examples for the various type of headache app. I actually found a lot of numbers, but I concentrate on migraine body and eye headache, and I found that both are designed by neurologists. The migraine body is most popular, and it has the option to add bodies, to add friends, so there are a social network sharing experience. And the eye headache has the option that it compares information with the International Headache Society criteria, which is an important in the diagnosis. I just put this slide to know that it's easy to use it. This application, you can just perform an account and use which type of headache, about the frequency, and this is a social network if you want it. And here is how to record an attack. If you have an attack, you just press on the start time. And during the attack, you can mention the intensity, the triggers, if there is a use analgesics, if there is any aura, the exact location, and then you have to end the attack. So it gives a reliable, easy way for the patient to give this information to his doctor. Finally, I will just highlight, of course, Dr. Tamer has mentioned our telemedicine unit and how its application was widespread, but I just will highlight the issue regarding to headache. This is our telemedicine unit, and this is our telemedicine team. It started approximately 3 years ago with the initiative of Treat and Teach, and the main target was the African countries. And this module is a teleheadache teaching module. It was given during the period of August 2016, and actually it targeted many African countries, and it was a video-audio communication, and it covered many types of headache topics, from primary to secondary headaches, and even there was a case consultations and clinical interactive discussion. As you see here, this is our audience. Actually, they show satisfaction with the communication, and actually they came later on and visit us and attending with us many activities in our hospital. And there was the interaction regarding question. It could be through the speaker or even through chatting. Then we started to manage outpatient headache. So we think about the online headache clinic. Actually, it started recently, a few months ago, and received several consultations. But still, I will not comment on the data. It is very limited. But as a global, most patients show satisfaction with the communication, and actually, the patient use their phone and make the conference through their home, and they found this an easy way to follow up with a specialist. And actually, most of them was using over-the-counter medications and several analgesics, which is not efficient for them and makes the condition more worse. Our aim is to expand this online clinic, to increase the awareness of people with it, and also to reach more people. And we try to perform an ongoing study and compare between the application of telemedicine in headache versus the traditional Ain Shams headache clinic in an Egyptian sample. And of course, we will try to overcome our challenges. And of course, we have problems with education, problems social, so we will face it, inshallah. Thank you.
What a nice hope. Dr. Nagib, have a question?
Thank you very much for your presentation. I think I'm also a member of our new group now and we collaborate. My question is with your e-clinic with the headache patients, do you work instantly, or maybe patients could leave a question or problem for you and you can solve it later on?
No, I actually started it recently through a synchronous way, an audio-video conference, that I see the patient at the same time and he give me the complaint. Of course, most of patients are seen previously by a primary doctor or a previous consultation, but they just follow up with me. And of course, all of them has problem with compliance. So all with a two-way communication. I'm not through SMS or WhatsApp or that.
By example, if you are not available, they are not allowed to keep messages.
No, maybe we'll increase this. I concentrate only about the online clinic, but maybe I will use the application the other way to benefit also from it.
I think I suggest to develop because I think our system, the Moroccan, Egyptian, and Italian, the dream system are quite different. I think we can make
networks and make questionnaires or research, yes. Of course, yes.
And to develop, I think also IHS, we discussed, they could also sponsor some program for Africa, and I think we can also get the website, their website, and I think we can record, and one of us or your team, we can also discuss about the language. So I think the barrier is the language. Make some program for education in English, some others in Arabic, for example, we can solve together.
Okay.
Thank you, it's very interesting.
Thank you very much.
Shahinaz, what a confident speaker, you and Tamer and what the others. Very quick question in a couple of words. How do you see this project 5 years from now, since you are the future, you guys, your age? How do you see telemedicine 5 years from now?
Actually, it started 3 years ago, and actually there is a rapid progress in it. So I think, of course, we have a limitation. We will have barriers. I would think we have problems regarding the payment, the insurance, the education of the patient. We want to target even the low-income patients, and this could be a problem because the technology may be available for them. But I think with these advances and with this rapid increase in the applications, I find hope, inshallah, that this will be will make research and will make a proper achievement in this, inshallah. Thank you.
Thank you very much. I think it is time now to do the reverse. We used to hear MS and have some rest by hearing other things in neurology. for the first time, we will have rest from headache. And we are inviting one of our expertise in multiple sclerosis to give the next symposium about something related also to headache, but in other parts. May I invite Professor Dr. Mervat Mustafa to chair the next session, which is a Merck symposium. حضرتك تقدمي دينا بقى.
Next lecture and presentation will be by Dr. Dina Zamzam, Assistant Professor of Neurology and Shams Faculty of Medicine in Egypt. The title will be MS and Migraine, Related or Coincidence?
Thank you very much, my dear professors and colleagues. Good news that I won't take the whole 25 minutes, and I hope I won't cause headache and migraine for the attendees. Thank you very much. First, migraine, as we all know, is a recurrent headache disorder with intense pain that may be unilateral, accompanied by nausea, vomiting, photosensitivity, and phonosensitivity. In spite of being painful, fortunately, it is not life-threatening. It is one of the common causes of recurrent headaches, consists about 16% of primary headache disorder, 12% of the general population. It reduces the quality of life in many persons who suffer from it. Approximately 40 million Americans have migraine, and it is underdiagnosed. Factors which trigger migraine may be change in weather, drugs, alcohol, caffeine withdrawal, stress, fatigue, hormonal therapy, diet, and hunger. Regarding the MS, it is one of the commonest causes of neurological disability in young adults in neurology. It is a chronic neurological disorder causing demyelination in the white matter. Recently, the gray matter is also affected. Females represent 70% of the MS population, and in spite of not being as common as migraine, it's still one of the important diseases worldwide because the number is increasing, expected in Egypt to be 30 to 50 per 100,000. This means that 30 to 50,000 young adults aging between 18 and 45 years. As we all see here, what happens is the myelin is affected, causing partial flow of information, and if we leave the patient without treatment, marked degeneration, axonal loss, causing irreversible disability will happen. So it's crucial to pick up the patients as early as possible. Causes of multiple sclerosis, genetic predisposition as any other autoimmune disease with environmental risk factors triggering the immune response. as vitamin D deficiency, infections, smoking, hormonal, heavy metals, also stress, diet, and obesity are risk factors for occurrence of multiple sclerosis. This is our new classification in MS. This is the previous one. Recently, we describe them as clinically isolated syndrome, relapsing, remitting, and progressive MS. The most common type is the relapsing remitting type, which represents 70 to 75% of our MS population. So what's common between MS and migraine? How are they alike? In demographic similarities, both of them have female predominance. They both affect relatively young age at age of onset. Both are more common in Caucasian compared to African and Asian population. The majority of patients, as we said, in MS have a relapsing remitting disease, which is a little bit similar to the episodes of the neurological symptoms or disability caused by the migraine. Both of those neurological diseases have stress as one of the major factors causing relapses or migrainous attacks. Which came first? As we all know, some said that the migraine is a triggering factor to cause MS. Others said that MS patients have higher incidence for migraine. This clinical overlap isn't recent. When I searched in the researches, it even started in 1952 by a study by McAlpin that he said 2% of the MS patients had migraine within the first 3 months of an initial attack. Women with migraine, when they were followed for more than 15 years, they have a higher incidence to develop MS than women without migraine. So, migraine can cause MS, and most people who have MS and migraines, migraine came first and not caused by the MS. It generally precedes MS by several years, and the rarity of migrainous attacks at the onset of MS indicates that it can be a pre-existing diagnosis. On the other hand, MS community said that migraine can be a subtype in MS. Migraine-like headache may be one of the presenting symptoms of the MS rather than a comorbid diagnosis. In some cases, severe headaches or bad headaches can lead to neurological examination in which, if we find a deficit, MRI brain is requested and eventually led to MS diagnosis. So, is migraine a precursor of MS? When they had a survey in 2010 for the migrainous patient, they discovered that 70% of them experienced at least once neurological dysfunction that lasted more than 24 hours, in which in our MS community can be considered as a time needed to detect a clinical relapse. Migraine occurs in MS twice as in normal population. The prevalence of migraine ranges between 43% to 72% in different studies. It's not typically included in our clinical features. Migraine alone couldn't be described as a relapse. We should have another neurological deficit to say that migraine with other neurological deficit is considered as MS relapse, although it occurs 2 to 3 times more frequent. And the most frequent type of migraine in MS is that without aura. The pathophysiology by which migraine can cause MS is that the meningeal irritation, which is a key inflammatory process in the migraine process, and the involvement of the tertiary B cell follicles. Also, the serotonin level with its changes in the brain can predispose to inflammation. The increase of the CNS permeability of the blood-brain barrier during the migrainous attacks can cause the T cells to migrate to the CNS and start the inflammatory process. Spread of cortical depression during migraine can unmask the MS symptoms. Release of the cytokines during migrainous attacks can predispose to autoimmune process with increased T2 hyperintense lesions, T1 gadolinium-enhanced lesion, and altered pain perception in migraine can lead to more symptoms prescribed by the patients, and that can represent an attack. What about MS causing migraine? Migraines are believed to be triggered in CNS special areas like brainstem. After the optic nerve and the spinal cord affection, brainstem is one of the 3 most cardinal sites for the demyelination in MS. This means that MS lesions can cause migraine. Also, patients with optic neuritis can experience severe painful headaches due to the optic nerve swelling, and sometimes this can be leading to pain similar to migraine. The DMDs, or the treatments of MS, can be one of the causes of migraine, and unfortunately the available medications can cause so, like the interferons and the fingolimod. It seems that patients who have more migraine as a side effect of medications have personal or family history of previous migraines. What's the pathophysiology by which the MS can cause migraine? The cortical demyelinating lesions can cause cortical spreading of depression, which happens in migraine. Lesions in the periaqueductal gray matter within the midbrain is suspected to have a role in migraine etiology, as we see here. This is the periaqueductal, in which the arrows showed. This periaqueductal gray matter lesions can cause migraine because it contributes into the antinociceptive effect, and it can worsen the migraine process with focal neurological deficits. Lesions at the dorsal horn of C2 of the spinal cord affect the sympathetic flow, and we all know that patients with migraine may have less sympathetic drive. Is there what's called migraine MS? That means that some of the MS patients may have a special pattern to have migraine as a comorbid diagnosis, and not one of them causing the other or preceding the other. Yes, they noted significant increases in those patients in pain and non-pain related MS symptoms. In the comorbid MS migraine group, it is relatively a group of younger age of onset. They have better EDSS in spite of pains, but regarding motoric and cerebellar affection are less common in those group of patients, and they have a shorter disease course, usually starting from the onset of the MS diagnosis. 15% of them may have recurrent moderate intensity headaches ranging from 2 to 3 up to 15 times per month. Our problem now is the faulty diagnosis of MS, or what's called overdiagnosis of MS, because of the new diagnostic criteria. That's why we should be very careful in diagnosis of MS in patients with migraine. Due to that, the aura of the visual symptoms in migraine can sometimes be mistaken with the optic neuritis. Hemiplegic migraine, which is a rare condition, can be mistaken with motoric relapses in MS, and unfortunately, unexperienced doctors or clinicians who can't read precisely the MRI brain can say that the white matter lesions in the MRI is considered as MS lesions. That's why we should carefully diagnose MS. First, patients should have clinical and neurological examination supporting presence of neurological deficit. Blood tests can be done in some cases if we think that it is due to collagen abnormality or vitamin deficiency. In some cases, we can reach up to CSF analysis to detect the presence of oligoclonal bands. And don't forget the MRI features in MS, as we see here in the brainstem lesions. This is the brain with the plaques of the MS on the other side, which is called Dawson's finger. And in front of you, the healthy brain. So we have to make sure that the MS plaques are present. Lesions in the spinal cord, which one of the cardinal signs of the MRI and cardinal features and signs in MS patients. And this is brain lesions with migraine. As we see, it's not in the typical areas of the MS. Sometimes some doctors can mistake migraine alone with MS, and faulty diagnosis can be made. In spite of that, early diagnosis of MS is crucial. So, as we said before, migraine can be associated with our relapses. There is what's called migraine MS subtype. Even the community of the migraine have a higher incidence, 2 to 3 times more common to develop MS than that of the general population. So please be careful to pick up our MS patients, because we need to treat patients as early as possible after the diagnosis of MS or even CIS. Early treatments decrease the number of attacks, the MRI lesions, and the most important, the disability progression, to prevent that our patients, which are full of life and walking, going to work, return to be disabled patients. In each plaque, we lose 11,000 axons in each demyelinating plaque. This can cause irreversible neurological damage, and unfortunately, 15 to 30% of the spinal cord lesions are lost before clinical picture takes place. So that's why it's very important to pick up the patients with MS who have migraine or migraine-related disorder. If we leave the patient undiagnosed, most of our patients will lose employment within 10 years of the diagnosis. 50% of them will be in need of walking aids by 15 years of onset. After 25 years of diagnosis, most of them with no treatment or delayed onset of treatment will be crippled or in wheelchair with less life expectancy by 10 years. So we have to pick up the patients early because time is ticking and time is brain. When we leave the brain to the inflammation, we lose more neurons, more axons. We have to pick up patients early, start treatment early, and reset the immune system. Please don't forget that time is brain is in MS, as in that for vascular or stroke lesions. What's lost by delaying early therapy is not regained by starting late. Treatments. We have symptomatic treatments to the symptom or the presenting symptom of the disease. We have treatment of relapses, which is mainly corticosteroids, intravenous or oral. We have the disease-modifying drugs, which is our cornerstone of treatment to prevent the occurrence of relapses from the start and not be just treating the symptoms. As treatment of symptoms in migraine, control risk factors if there is depression, fatigue, lack of sleep, or diet abnormality. If it is a side effect of drug, you can either change the dose or change the medication. During the attack, we can use non-steroidal, we can use triptans. If we think it's a part of MS relapses, steroids can be used. Antidepressants, especially SNRI, are important. SSRI are less effective except if the depression is the cause for the migraine. Sometimes we cannot use most of the anti-epileptics and available other medications for migraine because of drug-drug interaction by the disease-modifying therapy of MS, and nerve block in some cases can be the best solution to avoid drug-drug interaction if we cannot change the medications. Regarding disease-modifying drugs in MS, as you see, we have more than 12 disease-modifying drugs in MS. Most of them are not available in Egypt. Here we have the interferons beta 1A and beta 1B, and the gelenia or fungolimod available on the expense of the country or by the General Health Institute. This is the approved immunomodulatory treatments here. From them is the Rebef, which is subcutaneous, 3 times per week, 44 microgram. We have Avonex once weekly, betaferone every other day. Regarding the patients who don't respond on the first line, we have the second line, the gelenia, 0.5 milligram daily, and we are waiting for Thiasabri to be included according to be freely dispensed for the patients, which is given monthly, monthly dose every 28 days, 300 milligram. The most important take-home message is that neurologists see 40% only of our MS patients. In 40% of our MS patients, 30% only pick up the MS patients early. So please screen your migrainous patients, examine them thoroughly and carefully. If we could pick up the MS patients and prevent them from being crippled, this is important. Don't let this start lead to that end. Thank you very much, and this is my team in MS unit. Thank you very much.
Thank you very much, Dr. Dina, and we call for any question.
Yani, thank you very much, Dina, for the very nice presentation. And of course, we are all neurologists and aware of how important to start treating multiple sclerosis as early as possible. But I am just reminding myself and all my colleagues that the prevalence of MS, for instance, in Egypt, expect that we have 50,000 MS patients, while the prevalence of migraine in Egypt counts expected number of patients with migraine to be up to 17 million subjects, which is quite a difference. In fact, we have to consider the problem of over-diagnosis of MS in a very good category of patients with migraine. And this is, you didn't came across, so I wanted to stress it. Usually the MRI diagnosis of migraine or diagnosis of MS according to the MRI, overdiagnosis is due to the presence of white matter changes. White matter changes in migraine occurs frequently in females, especially in having migraine with aura and having frequent attack. These are very important red flags when you are seeing a patient with a probable MRI with MS and having a migraine, a female, middle age, frequent migraine attacks with aura. They frequently have subcortical white matter changes. So if you are in doubt, please don't rush on to diagnose multiple sclerosis and perform CSF analysis according to the last McDonald's criteria of 90
of 2017, the last criteria. Okay? This is also just...
Thank you very much. I remind myself and all the audience that I said that one of our problems now is the faulty diagnosis of MS. That's true. That's why we said there is overdiagnosis of MS nowadays, and this can be mistaken really with especially with the visual hemiplegic and the MRI. That's why I said in MS diagnosis tools, we need to make sure, as our professor said, from the presence of typical history and neurological deficit, the blood test, the typical MRI, and differentiate that from the brain lesions in migraine patients, of course, to avoid that overdiagnosis of MS. Thank you, Professor.
I have a comment over here in front of you. Yeah. This is just a comment. I've always told my patients that, because I'm in private practice and I have a great time seeing all these patients that come to me scared as hell with these white spots, and then I can reassure them. So I usually tell them that up to 12% of the population have these non-specific UBOs, and if you look at migraine patients, up to 48% of the population have these UBOs. But on the first day of this conference, one of our Norwegian colleagues, he was talking about these white spots, and he said they couldn't find any difference in the frequency of these white spots between tension-type headache and migraine headaches, which was very strange to me because that's the first time I hear this. I don't know if anybody has a comment about this or knows more about this.
It's usually common in the migrainous patients than in tension headache patients, as I read the literature.
Dina, thank you very much. It was a very elegant presentation. You mentioned very elegantly about the location of the white matter changes and other changes, and where MS trigger migraines, and you mentioned also where migraine early MS changes and all of this. How do you do the management differently when you have a migraine with MS or MS patient who has a migraine? How do you put your management plan? Because the symptoms are going to be different if it's subcortical or it's pain-related, brainstem-related, or others.
It depends on the history, the clinical examination, and the MRI lesions. If the patient had a previous history of migraine and the MS is the recent one, so we'll treat migraine as a different identity or separate identity, taking into consideration controlling of the risk factor, my choice of the disease-modifying drug so as not to aggravate her migrainous attacks, and we can put a prophylactic therapy of migraine. Sometimes, as I said, I can reach nerve block in some cases in which there is going to be a drug-drug interaction. But in one of two of my patients, when the migraine was the triggering factor, you should see if this plaque is recent in the brainstem or in the spinal cord, and I treated with pulse steroids as a relapse.
Try botulinum toxin with such difficult cases.
I really tried to try the botulinum toxin, but isn't available in our country right now.
Okay, thank you.
Dr. Dina, the prevalence, which is more with MS, migraine or trigeminal neuralgias and facial pain?
Do you mean in MS patient? Trigeminal neuralgia, of course, is more common in the MS patients than the migraine.
Especially the first branch?
In first, it can be a presenting symptom also, more common than migraine.
Okay. Thank you for your presentation.
Thank you very much for the audience, and I hope I didn't cause headache or migraine for the audience. Thank you very much.